Great. Well, our presenters today are Deborah Lane and Alyssa Meller. Deborah is a program specialist on the Network TA team here at RHI, providing expertise in strategic planning, business plan development, partnership development, collaboration, and care coordination to rural health networks across the U.S. She has a Master of Education degree in Adult Education and Training and Development and has over 14 years experience of leadership development within community collaborations. Her passion for improving the health of people in rural communities has led her to engage in care coordination and advise health-related organizations on effective collaborative efforts. And our first speaker for today will be Alyssa Meller. As the Chief Operating Officer of RHI and the National Rural Health Resource Center, Alyssa is responsible for overseeing program operations related to the organization's mission, including finance, technology, and human resources. She has over 10 years of managed care, Medicaid, and Medicare experience. Her experience also includes assisting in the development of care coordination models and establishing and maintaining collaborative working relationships with regulatory agencies, providers, counties, and state partners. Alyssa received a Master of Administration and Management with a concentration in organizational development from the College of St. Scholastica. Well, I'm now going to turn things over to Alyssa to get us started.
Good morning. As Becky mentioned, my name is Alyssa, and I'd like to thank you all for coming this morning for our webinar on Rural Health Networks, Care Coordination Models. As I'm sure most of you know, Rural Health Innovations is a subsidiary of the National Rural Health Resource Center, a nonprofit organization, and we are located in Duluth, Minnesota, and we really pride ourselves on how we connect rural health organizations with innovations that enhance the rural health of rural communities. The focus of our discussion today will help build an understanding of how utilizing a framework will build an effective care coordination program and gain insights on how the care coordination canvas tool will help identify strengths and gaps for improvement of current models. We'll also provide you with a common language and approach in working with care coordination programs. There are 6 critical steps or components that assist rural health communities in transitioning towards improved population health and value. RHI and the Center's technical assistance is grounding in the core areas you see before you. The care coordination canvas we're sharing with you today fits within the care management component of our framework, but as we review the tool and how we've used it, you will see how it pulls in and asks questions and requires the end user to think about and address all 6 of these areas. In 2014, the National Rural Health Resource Center completed its first care coordination comparative study. The intent of the study was to support rural networks in awareness and an understanding of emerging care coordination models. With the care coordination experience I had prior to joining RHI in the center and the information gathered in this study, it became very clear that there were 4 common components of a successful care coordination model. The care coordination canvas tool was developed based upon this experience. Originally, it was designed to help organizations develop their care coordination efforts, and it continues to do so. But we soon found how organizations with mature and well-developed programs were using it to strengthen and expand upon their program. We also use this canvas to set a foundation of what we mean by when we utilize the term program or process around care coordination and its models, or simply put, it's a common language for this discussion. It sets a really good foundation for a common language. Becky referred to a file download, the Care Coordination Canvas Guide, and I'm going to refer to that on these next couple of slides as well. But if you're able to download it, please do. So the Care Coordination Canvas really focuses its efforts around 4 targeted key areas. It talks through the target population, the assessment, the care plan, and the care team. Target population, when we're referencing that term, we're talking about and we're asking folks to define it around improving the care and health and reducing costs for a specific group of people. It walks them through and asks them to ask questions like, is it specific enough? Are you clearly defining the goal or outcome of the identified problem? And in order to do that, the target population must be specific and it must be measurable. How are you going to identify the target population once you've determined the need? We provide examples of where to look for the identified need through maybe the local hospital's community health needs assessments or public health community health needs assessments of identified needs in target areas, electronic health record data. If they're part of different payment models, do they have access to the claims data? Population focus, such as an age-specific group or a Medicaid population, Medicare population, registries, and if it's more of a community-based approach, and we'll talk about this later, are there referrals being are utilized for the population? When we talk about assessment tools, what we mean by that is a tool or a survey used by the care coordinator or the point person of the care coordination model to assess a person's level of need. There are two different assessment tools that are commonly used. Those that determine the level of risk or the need around social determinants of health, such as environmental factors, mental health, behavioral health, physical and psychosocial functional needs, or more on the clinical side, the risk or severity level of the diagnosis and or disease if it's more of a chronic care management care model. So the tool or the canvas walks them through and asks them, do you need one? What we have found is that commonly the target population is generally defined, even if it is focused around a chronic disease or a registry or a population. But what an assessment can do is help determine the level of coordination needed and what type of services are needed to maintain a person's current status or improve upon it. What type or how will you use it? Usually the type of assessment will be determined by your target population and the desired outcomes you're looking for. When we reference a care plan, what we're talking about and what we really strive on and we spend a lot of time talking about and what we've learned supported through these interviews is an individualized plan of care that is developed with the person and or caregiver and providers to identify the person's needs and goals and outcomes. So this tool helps walk the network and or the folks putting together their care coordination team on what is the approach that you're going to use to develop the care plan, meaning it should be developed with the person, and how are you going to do that? It should be based upon the assessed needs, not only clinical, but also the social determinants as well. It also accounts for the medical, behavioral health, wellness, and human service needs, those social determinants, and will incorporate existing care and treatment plan information. A common area that is wondering is what should the care plan include? And some of the best practices that have been identified are that it clearly states the goal or outcome that is developed with the person that the care is being coordinated, their clinical and or social needs, the instructions and interventions of how to reach, how to obtain those goals, and the care team members, including their contact information. One area that Deb and I have spent time talking about is those personal demographic information that are so important. Not just the name, gender, and address, but really where are they living? Who is their primary point of contact and taking care? Some of those things that those not softer areas, but those areas that are needed to help be part of the team in the care plan development as well too, is an interpreter needed as well. Some of those things that you need to know to effectively coordinate care with the person. The last area, or the fourth quadrant, is the care team. And we go back and forth between calling it an interdisciplinary care team or just shortening it to care team. But what we mean by this and what we're working through with folks is providers that are identified with the person and or caregiver that represents the clinical, behavioral health, social services, long-term care, and community resources needed to help meet the person's goals and outcomes. Some of the aspects of the team that this tool walks through is who is that coordinator? We use care coordinator in the most generalist of terms because we found through the 2014 comparative study and this study that Deb just is finishing up as well, that coordinator can be multiple different types of point people, from a navigator, community health worker, RN, and so forth. But it's going to be determined dependent on the needs of the population you're creating your care coordination around, what the focused outcomes are, can be, as well. And it also asks, how are you going to function as a care team? Are you going to have team meetings? How are you going to run those? How are you communicating to each of those members who knows their roles, expectations, and hands-off? As I've outlined, there are 4 components to the care coordination canvas, each necessary for a successful care coordination model. In 2014 study, we found that there are 2 additional components that are critical for success and are integrated in each of these 4 components. They are communication and technology. A few points about their contribution to the care coordination efforts are specifically under the care coordination, specifically under the communication aspect is, and that is on the screen before you, is the light blue cells or boxes on this table. Are how will you communicate with and engage the person in their care coordination? How are you going to let them know that they're part of this care coordination model and they have these resources available? How will the results of the assessments be communicated? Where will they be stored? Do the results need to be shared with the care team and so forth? How will the care plan be communicated to the person and included the care team? How will updates be shared and the care plan updated? How will the care team communicate with the person, coordinator, and amongst themselves? This is like our workflow, our operational processes. It's important to clearly articulate who does what then and then make sure it's written down. The second aspect that's incorporated, and I alluded to it a little bit, is the technology component. Technology plays a role in identifying the target population, whether it's an analytics platform, the assessment, different modes, paper, where is it going to be stored? Is it built into an electronic or care management platform? Technology also can be used, like I mentioned, to perform assessments, but another area, and we'll talk a little bit about some of the difference in our models that we spoke to, is how does communication and technology go hand in hand? How are they currently communicating? Some are via fax, using direct secure messaging as well too. So those are points of reference that we tried to bring forward in the initial planning and ongoing improvement of care coordination model development. Other considerations, and these we're really refining and developing and providing guidance as we go along and get involved with our networks, is the role of leadership in developing the care coordination model, not only for the support of it, but always incorporating it and looking toward those next steps of how can we expand and include different providers and care team members into our model. And what is the business model? How, of course, that age-old question of how are we going to pay for what we're doing as well too, such as primary care integration, is it health plan based, provider based, and so forth.
Good morning, this is Deb. And as you work with networks that are doing care coordination, you can use this tool to really help them move their care coordination efforts forward. If you sense something is wrong, by using the care coordination canvas, you can help them discover what that cause is. So the thing that's just not making everything flow as nicely as you know it could. This tool can be used to do some really serious thinking about beginning care coordination as well as taking and improving the work that they're doing. This time of year, my favorite thing to do, gardening, is winding down. And as I thought about gardening, I thought about this tool. Using this tool to find out what is wrong is kind of like discovering how to take care of the weeds in a garden. And networks have also talked about using it as part of their yearly evaluation of their care coordination efforts. Sort of like doing a soil test to see what could be added to make your garden grow better. Then other networks and programs have talked about using it when they wanted to expand to a new population. It's kind of like that time that I decide I want to take and make my garden bigger. Then others have talked about using it when they want to expand to a whole new kind of population, a whole new model of doing service. And that's like tilling up a whole new garden. This spring, Alyssa and I used the Canvas to help a collaboration determine its readiness to implement a new payment model. This is just like starting that brand new garden, going from only growing perennials and annuals to having a whole new bed to grow vegetables in. Now that you have an idea about the quadrants and the components of care coordination, I'm sure that you can see how a new starting program can use this tool to make sure that they're developing a sound and effective care coordination program. But something I think as project officers that would be helpful to you is to understand how mature programs can use this tool as well. And so I'm going to give you some examples of ways that mature programs can use the care coordination canvas as a powerful and effective tool to improve and expand their efforts. There was a network whose program was in trouble, just like this garden is in big trouble. It was experiencing a high rate of readmits, which reducing readmits and ED visits was the major goal of their care coordination program. So when looking at the canvas, they really felt that the target population was specific enough. But as they looked at the assessment tools they used, when they got to that part of the quadrant, they began to understand, to see a contributing factor to their program. They had the diagnosis and disease-specific information assessed, but they realized they were missing the social determinants of health. As they moved to the care plan, of course, many of those social determinants of health were missing, and they began to question if the care team was sufficient, all contributing factors to the problem. To make a long story short, they are now using community paramedics to go into the home of the person to do an assessment primarily focused on the social determinants of health. The case manager can do the medical assessments, but the nature of their job doesn't allow them to go and do that home visit. So the community paramedic works with the case manager to develop the care plan, and that community paramedic is a pivotal part of the care coordination team. A network leader said to me, "I feel like things are going pretty well, but I feel like there may be areas for improvement, but I don't want to fix something that's not broken. And right now, I need to report year-end numbers and processes to the board." This is kind of like wanting to take a soil test. Your garden is growing, but you have an inkling that things could be better and that you could add something to make it grow. I suggested that she use the care coordination canvas and that she pulls together her care coordinators, some clinical staff, and community-based organizations, and really go through this canvas quadrant by quadrant to take a good hard look at her program. They held the meeting, looked at what was going well within each quadrant, including the communication and technology, and then began to discuss what they wished for. As a result of this meeting, they found that they had a lot to celebrate, but they also discovered some areas that they could work to make things better. Is it time to till up new ground and add more space for vegetables? Is it time for one of your networks to expand their care coordination program? There are a number of networks that have expanded their program. One I think of in particular was doing care coordination for diabetes. They were reaching their goals that they had set with diabetics and felt that they were ready to expand to congestive heart failure. They had a session with the staff and used the care coordination canvas to go through the processes they had in place for diabetes and identified what they could use as is and what needed to be modified for their new target population. The Canvas gave them a framework to rely on to expand to that other population with congestive heart failure. Then there are times that you will choose to till up a whole new area or create a whole new garden, expanding from only flowers to maybe adding a vegetable garden plot. The Canvas proved to be extremely valuable for a network who had been selected to participate in one of the new episode payment bundles, the cardiac episode payment bundle. Alyssa and I led a workshop where they looked at the strengths and gaps in each of the quadrants in relation to the cardiac bundle. They worked on action plans to address the discovered gaps, all to have in place before they would be implementing the episodic payment bundle, of which now has been put on hold for further comment. But
didn't you say that, Deb, they're continuing to move forward with that coordination effort?
Yep, they're using so many of the gaps that they discovered and using those action plans in order to take and just make their current care coordination program stronger as they wait on CMS.
I hope as you work with grantees that you'll find the Canvas a useful tool as you move into the future with networks and their programs. The next thing that we wanted to share with you is the care coordination comparative study or review that Deb and the team has just finished. As mentioned, the center did its first review or study in 2014 to support rural networks and awareness and understanding of emerging care coordination models. Care coordination has changed almost as fast as technology. So we wanted to look again at care coordination approaches to help organizations and improve and expand their programs. We interviewed network organizations across the country. This time we used the Canvas as a framework for review instead of it becoming an outcome of our initial interview. The methodology that we used is we interviewed 9 networks with established care coordination programs. The data gathered through the interviews and the questions developed from the Canvas was then transcribed into the care coordination Canvas for that network to review and reflect on and provide any edits if we misheard or didn't explain further or clearly enough what they were doing. We then, last week, I think it was, Deb, convened a focus group to review the results or the data collected in those interviews and shared with that focus group and asked, and Deb walked us through a facilitation of similarities, differences, ahas, and barriers that were identified as well. We're using that information from the interviews and the focus group to compile a written report for the federal office, and then also to help support and develop ongoing and continued educational tools to help networks and communities develop their care coordination model and improve upon them as well. What we found from a similarity, and this is a high-level synthesis of those nine interviews. The aim or the goal that they focused around, all of them focused around a decrease in emergency department utilization with an increased focus on primary care utilization. So if they could continue to improve upon that outpatient coordinated care, it would then decrease the acuteness and the level of that higher cost and the emergency department utilization. The target populations focused around chronic conditions, high-cost patients. Most started very narrow and expanded their breadth of who they were working with. What I found was really encouraging from my experience, and I like to see, is that the engagement aspect of how they identified or worked with a person that may have triggered for care coordination is that first engagement across all 9 models was always in person. They found that very beneficial to build a rapport, to build trust, and to explain the goals and outcomes and to develop that care plan with that person. Most of them engage the family or caregiver as part of that care coordination as well too. The assessments varied depending on that chronic disease, so they were clinical focused or behavioral health focused. Some of the more community care coordination programs, their assessment focused around those social determinants of health. And then this was a really interesting one too, is the medication reconciliation. And so they were really focusing their assessment and looking at the people that they were coordinating care around, the medications that they were all prescribed, and really focusing on efforts of reconciling those as well. And they all had care plans to varying degrees. Some of the differences in those 9 studies, those 9 interviews that we found, were in the, one of the predominant areas was that the care team aspect. Those that were more clinical based or focused, heavily focused on their care team as being very clinical. Very few community social organizations as well. The social service or community-based networks had a much more inclusive care team or who they worked with, but to include clinical providers as needed as well. The technology used amongst the care teams varied widely. The clinical, and I don't know if this was a surprise because most of them tended to be hospitals or clinic-based, often used their electronic health record or sophisticated care management software to help that communication. But others used more varying levels from paper and fax still, and software for or email, secure emailing or direct secure messaging. The person's experience, Deb and I use person instead of client, patient. It's much more inclusive and not informal but personal. So the person's experience within the care coordination model varied greatly from the number of touches, meaning how many times the care team interacted. Some were prescribed, some were based on the level of need and where that person was at in their care. The length of the program varied. There was one model which it lasted a year and they were done. You know, their model was very succinct and concise, and that the person was graduated from care coordination. And then the mode, how the person was involved on an ongoing basis of their care coordination. The financial aspect or that business planning aspect also varied. All of them had upfront grant money to get their care coordination model going. The clinical models had a much more opportunity to bill for services through patient-centered medical home, chronic disease management through CMS, behavioral health case management as well. Whereas the community health worker and coaches models, that was the primary model, used the grant money and were really working on gathering outcomes and evaluation metrics and hoping that that return on investment that they could showcase would then help pay, so their partners and other providers would help pay for that, their services. The school-linked care programs would have some billing aspect, but also were relying on in-kind time from their partners and using and tracking their metrics and outcomes for some return, to show that return on investment as a part of their sustainability plan. Assessments varied as well too, from self-efficacy to the knowledge of the medical condition and really the level and need in those areas. The care plans different widely as well too, from a clinical focus of therapy and things like that to personal goals and what the person and how the person was going to engage in their care differently or do. Care team development and communication varied in different levels too, and I think it worked at the level that each care team and model needed it to. Some were very formal, where they had a set huddle time or a meeting time that they met weekly or monthly. Some were much more in passing hallway conversations. And the communication, as we've mentioned, was electronically or in person, or based when the person asked for it. Insights that we've gathered from these nine interviews can really are good reminders as for our team, and I think for all of us here to remember, is communication when intentionally to your own horn. So communicating the results, the small wins, the story that happened, and all that's been accomplished is so important, especially with the care team and the partners in your network and community, to show the significance that you're making. And it helps support the patients and and the time it takes to collaborate and build those communication and those workflows. You got to be agile. That we heard this time and again. You build your plane as you fly. You may have the best intentions of how your model and how you're going to work and communicate, but there's going to be a hiccup along the road, and that's okay. That's how you learn. But you need that process. You need that guidance of a process and what to fall back on when you're starting to feel a little overwhelmed and needing that direction. It's good to have that foundation to work from and to go back to. A couple of insights from the interviews as the program matures is that we asked them, and what they shared is as their programs grew and more experience came, they found that sometimes their care plans became less clear and detailed, and also the care team meetings were more passing conversations in the hallways. And we talked about some of the common differences is that they were less formal and more casual. And this was a concern that they expressed as they've moved forward and matured, that they were getting lax in some of those foundations and process. So they warn, have caution. Processes are set up to follow for a reason, and if there is change, it should have an intentional reason for that change. Some of the insights on collaboration is that it's essential to building a care coordination program. They strongly encouraged and stated not to relax in this collaboration. It's a continuous process. Members and dynamics of organizations are continually changing, and as your program evolves, so will the need for changes in how you collaborate and work together. Because of the study, we see the importance of adding collaboration to this quadrant in Canvas, and we're starting to think through is how are we going to incorporate how to do that and to think that through as folks are developing and maintaining and expanding upon their care coordination program. Champions. It's the same for the true of champions. As staff changes with responsibilities and needs of each organization, you need to keep finding the champions and to showcase and communicate and maybe even build collaboration and or value into the why you're continuing to do what they're doing. The last area on the insights is that from those models that are solely focusing on clinical models, what they're learning is, or what they're learning, the importance of what the more social and community models are sharing is that there's a lot that goes in. That there's a lot that goes on outside the walls of a clinic or hospital that affect health outcomes. So the clinical portion is just the tip of the iceberg, that they need to be conscious and work with those community providers and behavioral health providers and organizations of those social determinants and needs and how to incorporate that into their clinical care coordination model. Technology, you need to continue to push forward how technology can help improve efficiencies and communication with data analysis and so forth. This is probably one of the biggest areas of frustration that we heard with these 9 areas, but there are solutions, and that don't be afraid to push through those concerns.
I'd like to spend a few minutes describing what it would be like to be a person in 4 different approaches or models. What would it be like if you were experiencing care coordination, or would be the person that a more clinical approach or model would be using? As explained by one of the programs interviewed, if you were eligible, you'd be notified to come in for your annual wellness visit. And during that visit, the provider would introduce the care coordination program and encourage you to participate as a beneficiary, take advantage of it at no cost to you. If the care coordinator is embedded in the practice, which a lot of care coordinators are, they would meet with that person the day that it was introduced to you and set up a follow-up appointment. The follow-up appointment would consist of another health risk assessment that is very focused on social determinants of health and some of the factors that might be impacting your clinical health, but around that social determinant in nature. This meeting with the care coordinator would take up to an hour, and it would be just identifying things in your life like transportation, issues with understanding medications or access to medications, nutritional status, and things like that. The care coordinator isn't addressing any kind of clinical interventions here. They're really focusing on all of those social needs and helping them get connected into the community with those potential services. Action plans that are developed during the first visit might very well have some sort of non-clinical goals like walking more or some nutritional goals. After that initial face-to-face appointment and the care coordinator was able to work on some of those community needs, then there's a follow-up with the person either by phone or by face-to-face. They encourage that the first appointment be face-to-face. As Alyssa was talking about, that is a really common thing throughout all care coordination models that are successful. But after that, realizing because of the nature of the rural people that we work with, it may need to be a virtual visit on the phone as follow-ups, or even in some cases through patient portals if they're utilizing their own electronic medical record. But the documentation for really all of these clinical models is always done in a centralized database housed within the healthcare facility. There would be follow-up until the provider and the care coordinator and the person felt that they've met their goals and that they're able to sustain on their own. So what would an experience be like if you were embarking upon a community health worker approach or model? Well, the first step would be to gather information on demographics, family history, medical history, medication adherence. They look at the healthcare utilization, insurance, Medicaid status, who is the primary care doctor and how often are you seeing that primary care doctor, or what prevents you from seeing the physician. Next, they look at needs related to food, transportation, and all of those social determinant issues. Then the second step would be to develop a care plan based on the information from that initial meeting and assessment, and really looking at what's most important to that person. What are some of their personal goals? Maybe they really want to go to the doctor, but they haven't been there because they've been unable to obtain a medical card. They may be unsure who they should go see or even where their local clinic is. So by taking and providing them with a list or taking a very heavy hand in helping them get that doctor's appointment. So sometimes that community health worker may actually make the phone call to get the appointment versus just giving them a phone number. And other times, even taking it a step further, because some people they work with are really afraid. And so that community health worker will accompany them to that first doctor's appointment. They break down their care plans very simply. There usually is no more than 3 goals with 3 very simple and specific action steps aligning with each of those goals. If somebody presents an issue of getting to a physician, it's not as simply as saying, well, I'll make you an appointment at the clinic. It's actually going into breaking down the steps to making that call, finding transportation, getting an appointment set so I can be home when my child gets off the bus, and then the community health worker will really follow up very closely before that appointment to make sure that they're getting to the appointment, and then also after, and do the same sort of hand-in-hand things with you throughout all of your goals. Then there's the care coach model. We often know a lot about that clinical model and the community health worker model, but that care coach approach is just a little bit different. Once the care coach receives the referral, the person is visited in person by the coach. Most often it's in their hospital room before discharge. The coach will explain the program by the use of a flyer and then introduce what's called in one of the most common models, the green book, which is actually personal health record. So if you're working with a network that's doing a care transitions coach model, you're going to hear the green book, and that is a personal health record. It's a small book, like about the quarter size of a typing sheet of paper. They are told about setting personal goals in this initial conversation and how this green book will guide their way to better health, along with 30 days of follow-up. And at this point, the person is given a choice to participate or not. Once in agreement to participate, an appointment is made to do a home visit within 72 hours of discharge from the hospital or from the emergency department. This home visit can take up to 90 minutes. And during this first visit, personal goals that they would like to achieve in the next 30 days are established and written into the green book. And all their medications are looked at and recorded in the green book and checked for polypharmacy. Discharge papers are reviewed to make sure that the person is compliant with them and, most importantly, has already set an appointment with their provider, and if not, help them set that appointment. Questions for the provider are also written in that green book. The care coach will discuss warning signs of their condition getting worse and review that with them and help them establish an action plan for if that happens. The person will receive 3 calls generally over the next 30 days as how they're progressing on their personal goals and to answer any other questions. Final approach model that's different is, what would it be like if you were a parent or a child in a school-linked or school-based model? At the beginning of each school year, a parental permission enrollment package is received from the school, from either the school-based health center or from the principal's office, and sent home and is to be returned. So it's in effect for the year. If the child comes into the nurse's office with an injury or a complaint or something that they need to be seen for, the parent is called. For example, if a child comes in with a rash on their arm and the staff can't really identify what it is, the parent is contacted to verify permission to seek treatment. And then the school nurse or school-based health coordinator will set an appointment through telemedicine for the child. Usually within an hour or two, the child will be seen by a physician through telemedicine to determine what the rash is and what kind of treatment they need, and if there's some sort of follow-up treatment necessary. If the child needs a prescription, that prescription is called to the local pharmacy or the pharmacy of preference that the parents have indicated on their permission slip, and the parent can then pick the prescription up on their way home. Sometimes they can even make arrangements to have the prescription delivered to the parent if that would be most convenient. The school nurse will follow up with the child to determine if the treatment is the correct treatment. If it's something that's severe, then the child would be sent home following their telemedicine appointment. Otherwise, the child goes back to the class, so that they're not missing as much school, which is the goal of this type of care coordination, is to keep kids in school and have them healthier longer. Another approach in the school is similar up to the point of actually making a telemedicine appointment for them, is that there's permission slips received from parents at the beginning of the year, and if a child presents themselves with a illness of some sort, then the parent is called and an appointment is made for that day at the clinic. They'll receive priority appointments because of their illness and that they're attached to that school-linked health care. Well, as we move further into healthcare transformation, care coordination is going to be more and more instrumental in making that happen. Projects that you will be working with in the future will include care coordination. So it's our hope that you now understand how a framework builds an effective care coordination program, and that you have some insights on how the care coordination Canvas tool will help you identify strengths and find gaps for improvement, and also finding that you have more confidence in working with care coordination programs. And I thank you for spending time with us today, and I just would like to open it up to see if anybody has any specific questions that they would like to ask.
Feel free to enter questions into the chat box, yes, or press star 2 on your phone to unmute your individual phone line.
James.
Hi. I have a question about the care coach. I've heard of this before, but I don't know if they're a common practice. And based on the description, it sounds like they're a little bit more clinical than a CHW would be. I know you talked about polypharmacy and a few other things. Are they, do they have a different level of certification, and are they reimbursable? Because like I said, they sound a little bit more clinical than a CHW.
In most of my experience with care transition coaches, they are RNs that have been trained, and the most common care coach is the care transitions coach, which is a trademarked program out of Denver by Coleman, Wyman Coleman, I believe it is. Yeah, I'm sure that's what it is. Anyways, then they go to this training, and it's very prescriptive. It's been researched, so it is really at the top tier of evidence-based programs. And like I said, most commonly it is like a lot of parish nurses, which are RNs, are trained in it, as well as in two of our networks. They do happen to be RNs that have been trained in the program. I don't believe it is absolutely necessary to be an RN in order to be trained, but right now, from the best of my knowledge, there is not reimbursement for it, because they do a lot of focus on them setting their own personal goals. A care coach would not go to a doctor's appointment with you. A care coach would not call to organize transportation for you. They would practice with you to do it for yourself. But so there's a difference there, and I think that's a part of why it's not reimbursable. However, many of these programs are really seeing the decrease in readmits. There's some statistics, again, because of it being evidence-based. I believe it's 65% of people who have a care transitions coach will not be readmitted to the ED department within 30 days. And the two networks that are doing it, their track record is a lot better than that. It's almost like 98% are not being readmitted within those 30 days. So does that help?
Yeah, it does. Thank you. Just so if an RN, and this is sort of a little bit of an aside, but if an RN could typically bill for things and generate revenue for a hospital or a clinic, are facilities more willing to have this physician because of their reduced admissions, and that they're saving a lot on that end? Because like I said, typically you would think that they would sort of like want to put them to work on things that would actually generate a revenue and could be reimbursed. So, do you know what I mean? Is there like a reluctance to have those because you're using somebody who is skilled that could be getting reimbursed on something that isn't reimbursable, just because in the long run it pays off?
That's a good question, and I think it depends, this is Alyssa, on the level of expertise of setting up billing practices at the entity. If those clinics or hospitals are part of maybe patient-centered medical home or the chronic care management code that CMS is really promoting and utilization of, they're more apt to use that, and this might be a tactic. A care transition coach may be a tactic on how they're going to do some of that to meet those chronic care management goals or patient-centered medical home goals as well. Some of the more informal networks or partnerships, or maybe they're community-based, that are utilizing an RN as part of another clinic or part of their partnership. I'm hearing, and when I'm working with them, is it's a lot more struggle to figure out how to bill or to follow those processes that are outlined for you to bill, then they're finding the worth of it at this point. And so what they're hoping is that the return on investment that they're showcasing, the outcomes that they're seeing, will then be sellable to other partners, maybe payers, if depending on what state they're in, as well as services to help coordinate that care better.
Okay, that makes sense. Thank you.
Because what a care coach is doing is getting a person to set their own goals and be responsible
Motivational
for
interviewing and things like that. Okay.
And plus a little more than that even. And in the true clinical model, it's more directive in what they're supposed to do.
We'll do this, or
right.
you need to do this versus they're transitioning their language and incorporating some of those tactics, but it's more care management focused. Focused.
So you can see how that care coach just doesn't quite fit underneath the community health worker model or underneath the clinical approach. So it's different, but it works in some situations really well.
It's a short-term care model, transition model.
Okay.
Deb, this is Cap. I think I heard you mention community paramedics, but I don't recall if it was associated with one of those particular models of care coordination. Is it the case that community paramedics fit better in any one or more of those models that you heard through your interviews and data gathering?
Well, natural fits for community paramedics would be in that clinical model as well as in the community health worker model. I have not heard of any school-based ones using community paramedics because that nurse is kind of like the community paramedic in some ways in that model. Yeah, because they're right there. I would imagine if somehow something, needed to be seen in a home, that the community paramedic may be a part of that. The care coach model, really, the community paramedic can use some of those skills of the interviewing and self-motivation, but it doesn't naturally fit within that model either. So the two that you would see, really primarily it's that clinical approach because it's that wing out in the community that the clinical employees can't get out into the community by nature of their job. And so that community paramedic in the situation I was talking about definitely was that community arm out there. So, and I know community health workers have worked with community paramedics, and community paramedics have been trained as community health workers as well. So.
Great, thanks. And just as a follow-up to that a little bit is in the idea of the community paramedics and the community health workers that are doing the home visits, have you, speaking of it, and that leads me to think about technology, and I know technology is one of those aspects of the care coordination models that goes across. It's a part of each, no matter what approach, there's technology included. And you mentioned telemedicine specifically, but I didn't hear you talk too much about the mobile medicine, mobile use of technology. So did that pop up during your data gathering?
Specifically in some of the models, they do have computers that they take with them if they do go into their homes. Most commonly, the care